He's an intensive care nurse and he's the research manager at the Austin Hospital. And he's the principal investigator on an NHMRC-funded trial, which is the TAME Cardiac Arrest trial, which is investigating mild hypercapnia in the ICU. So thank you, Glenn.
Thank you, and thank you to the organising committee for the invitation to talk. Thank you to the chairs for hosting the session, and a wonderful group of speakers that I get to speak amongst. So welcome to the afternoon. I'm here to talk about the TAME Cardiac Arrest trial, and I'm here to talk about research surrounding cardiac arrest and more specifically the TAME trial and where it's at the moment. And the reflection I had on finding the forest for the trees took me back to think that I'm one of many trees in the TAME Cardiac Arrest trial, but I'm also one of many trees trying to focus and understand the impact of cardiac arrest not only on patients but on the community, and to make a difference in those outcomes for patients and their families and their relatives and the society in which we live. So the broader picture, or the bigger picture, does impact people on the local level. And I'll just show you one reflection was, I got thinking about the topic, and I was thinking about myself, and I was thinking about what happened to me 4 years ago, and I wrote a letter to Ronaldo, and he fortunately published it in the journal Critical Care and Resuscitation. And as I was described, I'm a research manager. I get to see all the patients in intensive care each day, screen them for trials. And I turned up one morning and went round to C10, and there was a cardiac arrest there. Great, I was doing a cardiac arrest trial. And then it hit me. This gentleman was like me. He was a dad. He had children, he had a job, and the night before he was playing with his kids. And then all of a sudden, he had a cardiac arrest, went to the intensive care. I had my dinner and I went to bed. But I came there that morning and I realised all this. And it showed me the ripple effect of cardiac arrest, not only for that individual, but their family, and then his ongoing care. And I was really moved by that in such a way that I wrote to Ronaldo and told him that. And it really is a disruptor. Cardiac arrest isn't something any of us want or any of us really expect, but it happens. Naturally, there's thousands of studies being done, and they're all very worthwhile, but the therapeutic targets are out there. We need to find them, and then we need to implement them as soon as possible. So cardiac arrest in survivors is so dramatic because of the impact of the arrest on the brain in the resuscitated person. Early post-cardiac arrest results in low blood pressure to the brain and low blood oxygen in the brain environment, as demonstrated here by a positron emission tomography scan in day 1 in a post-cardiac arrest patient. Blue represents low perfusion to the brain in this patient. So despite adequate blood pressure, you would imagine a heart rhythm, they're on a ventilator, the brain is not a happy place in relation to perfusion. Concurrently, it's known on the right-hand side that patients who present or have low cerebral oxygen values in the early post-resuscitation period and then through to day 1 and 2 do poorly compared to those who have higher cerebral oxygen values. So the brain is acutely affected and sustains injury that goes on during the early resuscitation and reperfusion injury period. And that when you're in intensive care and you've been resuscitated but you die, it's not that your heart gives up, it's actually that your brain has suffered significant failure and it's no longer working adequately, or you are deemed to have a very low chance of a favourable outcome, and the more humane decision is taken often to withdraw life-supporting therapies. The response to a cardiac arrest and the research that's getting done can be described in broadly 2 phases, at the setting and during the resuscitation period, and then there comes the post-resuscitation period. So you have blood pressure back, come to hospital, leave hospital and rehab. And this sort of chain of survival, as we describe it in the cardiac arrest literature, covers the arrest, resuscitation, immediate post-resuscitation, and long-term outcome evaluation that's getting done. Just so you know that there's tons of bodies, institutions and guidelines available to help focus our attention and adequately support the care that we give it to cardiac arrest patients. And our guidelines from the Australian Resuscitation Council and these other esteemed bodies are often published under ILCOR as the International Liaison Committee for Outcomes. So this is where a lot of the evidence is brought together to provide to you as clinicians to guide the care that you provide to the patients that you see. So I'm going to take us on a quick journey through the research to date, looking at the pre-hospital hospital and then some out-of-hospital research that's getting done, and then show you why and where the TAME trial fits in and why it's so important in this whole chain of survival and chain of survival research. We're very lucky that in Australia and New Zealand and in many of the developed worlds, we have rapid emergency medical response systems. They're being evaluated, they look at their data and they want to get better. Then again, there's efforts to be made in the community to make people like us first responders so that we can get there quicker than the ambulance can get there and we can start bystander CPR. So you might have heard of the GoodSim app being rolled out in Melbourne at least, or Victoria, that you can say, I want to be on this, and if there's a cardiac arrest nearby, let me know. It might be 2 doors down. I can get there quicker than the ambulance that could get there. And this is like, if you're at the moment registered with APRA, so the Australian Health Practitioner Registry, you can volunteer to go on it. So that's trying to help in this pre-arrest period to get people there. They're trying to gauge AEDs, or automated defibrillators. I imagine a place like this probably has 4 or 5 spread out around the place, so there's rapid ease of access to a defibrillator. And then there's devices that get implemented quickly at the scene to help with cardiopulmonary resuscitation. And then again, simulation. We all go to advanced life support courses or basic life support courses, and there's even training in the field to help understand, practice and evaluate to reduce variability. There was a recent trial called Paramedic 2, and this was a very large randomised control led by our colleagues in the United Kingdom, and it was evaluating epinephrine, noradrenaline, in the community for out-of-hospital cardiac arrest. It was really well done, very well conducted, and it compared the group of patients and their functional outcome using the modified Rankin score. And for those who do or don't know the scale, that's not important. There actually wasn't a difference in the outcomes, but there was actually a trend towards a poorer outcome in the patients who got epinephrine. They did worse than those who didn't get noradrenaline. So the question of giving adrenaline, I think, is still under question, because patients who got noradrenaline, even though they had a poorer modified Rankin scale, it would suggest to me that should we have a therapeutic benefit in some other aspect of care, it may be advisable to give epinephrine to give us time to implement the other thing that we don't know yet but might find out soon. So the Paramedic 2 trial is very interesting. In the hospital, which is where we are, there's another broad range and variety of research being done. There's early angiography and getting patients to angiography-prepared places. There's evaluating titration of various oxygen and carbon dioxide targets, of which TAME is, carbon dioxide. They're also looking at the different and various neuroprotective drugs that are available and being studied. So we have angiography, which is a physical thing. We have gases, which we're looking at. We're looking at drugs. And importantly, we're still looking at and evaluating temperature. Is it better to have someone cooled, therapeutic hypothermia? Maybe it's satisfactory to avoid fever, or are we somewhere in between, which is best? The therapeutic hypothermia story is really quite interesting. It began back in 2002. There were 2 studies published, showed a difference in the delivery of targeted temperature management early on, and there was a favourable disposition towards the outcomes for those who were cooled, and then ever since 2002 there was this rapid uptake of cooling patients. That was very interesting. Everyone was sort of convinced and doing it except the Swedes, who then went and did the TTM1 trial because they felt the earlier work lacked the scientific rigour that it deserved. They did an extremely well-conducted, large, multi-centre randomised controlled trial called the Targeted Temperature Management Trial. Great separation again in patients who are allocated to 33 degrees compared to those allocated to 36 degrees. And here, unlike the early studies that showed a benefit of cooling, when patients, there was no statistically significant difference in the outcomes for the 2 groups, whether they were cooled to 33 or cooled to 36 degrees. What I feel has happened now is that there's been a sort of mixture of approaches taken in the temperature management. So again, we're not really sure on how or how long temperature should be conducted or controlled in this patient population. So they're doing the TTM2 trial. And then just briefly, the research going in the post-hospital care, would be the things that you would expect for any other chronic or acute condition. It's looking at the patient and what they can do, rehab classes, building a support base and fundraising, and then also having organisations developed to help support post-cardiac arrest care. Sadly, all my wind to date and talking hasn't really demonstrated a benefit to patient outcomes. And I show this slide because it shows that the ICU and hospital mortality for patients admitted to the hospital following a cardiac arrest have been largely unchanged over a 10-year period in Australia and New Zealand. So we've been cooling, we've been temperaturing, we're getting there faster, we're trying to give drugs, but something's not happening to improve the outcome of patients. So maybe we need to try a new approach, and this is where TAME comes into it. So TAME is looking at arterial carbon dioxide. So it's a ventilation study. We're looking at arterial carbon dioxide because it's the major physiological controller of blood flow to the brain. Remembering the brain is an unhappy place early post-cardiac arrest. And elevated levels of carbon dioxide result in dilation of the cerebral arterioles, so there's some physiological response to getting extra blood flow to the brain, which we think might be where it's needed. So much so that targeting mild hypercapnia, so slightly higher than normal levels, may result in increased perfusion and subsequently increased cerebral oxygenation in this group. In the intensive care unit, arterial carbon dioxide is highly monitored, regulated, and we can adjust it quite easily when they're on the ventilator. Increase the respiratory rate, decrease the respiratory rate. We can hopefully get them into a sweet spot. So being a modifiable component of care, it may also be a therapeutic target that's modifiable and achievable. The TAME trial began its life back in 2009, 2010, and it's taken a nice journey, gaining credibility and momentum along the way, so much so that it's started now. Sites are now recruiting patients into TAME. TAME's ambitious. We hope to get to around 80 sites in about 16 countries around the world. At the moment, our colleagues in New Zealand, many of our colleagues here in Australia have started recruitment, and early through the remainder of the year, our sites through Europe, Scandinavia and Ireland will take part. It's managed this way, so we have some funding for the trial from the Irish Healthcare Research Board, and they're coordinating sites in these countries, whereas the ANZIC Research Centre is the one that we will be dealing mostly with down here, and these are the project managers responsible for it. I won't go into too much detail because I've already got my 5-minute warning, but we're looking for adult out-of-hospital cardiac arrest patients that have sustained ROSC for greater than 20 minutes and are being admitted to intensive care for ongoing management. And we want to get them in early, so there's a time constraint of 3 hours from the eligible ROSC. It involves coordination of effort, of timing and efforts, and people to get to ED to help. And we just want to exclude people with known contraindications or known poorer outcomes. This is the schema. We have 1,700 patients as our sample. We have the patient having their cardiac arrest. We have the intervention applied, and we're targeting mild hypercapnia, 50 to 55 millimetres of mercury, or normocapnia, and we provide some guidance to clinicians about how to adjust the respiratory rate to stay into that target. And then we're having the primary outcome. And the primary outcome for our trial is the Glasgow Outcome Scale Extended, dichotomous outcome of favourable versus unfavourable in survivors. I know the GHOST, you all know it so well, but I'll show it for those who don't. It's actually an 8-score category, 1 being deceased, 2, 3, 4 being the lower levels, and then 5, 6, 7, 8, with 8 being good recovery. So really, we're looking at those who are assessed as being favourable compared to those who are assessed as unfavourable as our primary outcome. Within all of this, we have a wonderful opportunity to learn about neurological prognostication and assessment so that we can best understand what we're doing now to inform you, to tell you and give you certainty when you're speaking to family about neurological outcome and assessment, and importantly about withdrawal of life-sustaining therapies. Above this, we're also looking at biobank. Jason was talking about the Indigenous population. Maybe there's different genetic factors at play, and also different effects on the brain, the heart, inflammation, and the genetics of patients in the cardiac arrest. So we have a biobank embedded. We're co-enrolling, very friendly with co-enrollment with many studies. Let us know if you want to be co-enrolled. We'll talk about it. We've got web-based randomisation. It can occur in the emergency department. It's very easy to do. I did it in the car driving to the airport to get to Noosa last March. I was able to enrol someone, so anyone can do it. Electronic data capture. And importantly, we have wonderful coordination and support. So in Australia and New Zealand, or for Australia and New Zealand mainly, it's Bridget Adey and Vanessa Singh at the ANZIC Research Centre. But if you do happen to find yourself in Ireland, please catch up with Kate. Kate's up there and managing the project manager up there. So in my final slide is we've started recruitment, started randomising and enrolling patients. We have 24 to date. We've got a few more to go. It's not too bad. I think once we hit maximum study site saturation, we'll see a rapid uptake in recruitment. But I would urge you to participate, help us to learn, provide the answer, and engage with your ED colleagues and your ICU staff so that we can make it a rapid process. I provide updates on Twitter, so if you tweet or don't tweet, follow me, follow TAME, and I look forward to sharing this journey with you. Thank you.
Thank you for that introduction to the TAME trial. Are there any questions for Glenn?
Question is about the overlap of TAME with TTM2. Because as I understand it, patients are being randomized into both trials, and how that will sort of influence either trial. Because, for example, in our unit, we opted out of sort of TTM2. We're doing TAME only because of that concern.
So there is sort of scientific concern that we are aware of with when you may have an interaction between two carbon dioxide levels and two temperature levels. Broadly speaking, now that the trials are underway, there is actually this beautiful Venn diagram that there is about a third of sites only doing TAME, there is about a third of sites only doing TTM2, and there's another third in the middle there doing both. So we'll have this wonderful 2 trials that are really doing 3 trials that will answer your question. So in the TAME-only centres, there'll be some centres there that practice strict targeted temperature management and some a little bit more wild type. And then the sites that are in TTM2 will have strict temperature control, but maybe a little bit more variability in their CO2 management. So we'll be able to see this and actually explore it in a rigorous scientific way. And then for the patients in the middle, it's actually a 2x2 factorial design that will answer the question, gee, what happens if they're low CO2, low temperature, or high CO2, higher temperature, or avoiding fever? So the studies will actually help your site, our site, every site, to understand no interaction, crossover, not crossover. So we're aware of it, but I think we're actually doing the sensible thing by enrolling patients into randomised trials that will randomly allocate them, and then we can do the statistical juggling at the end to tease out the difference, because it may be low temperature, high CO2 is good, or both, or not. I don't want to estimate, but we're in a wonderful position to find out.
Can I just ask, so do you think, however, the number to treat, the actual number to conclusion is going to change, or it won't be affected?
True, so it's the size effect. I don't think it'll be affected. I don't think so. Yeah, I think both trials will be adequately powered based on the studies as they've been set up and designed to, and you won't see it, but we have this opportunity to learn, and in the end of it we'll end up not only with a study of 1,700, TTM2 is 1,900, so we'll actually end up with a study of around 2,400 patients that are all enrolled with the same eligibility, all have the same data collection, all have the same follow-up, and we'll have this wonderful database to answer all these questions. We really will. Anyone else?
Yeah. Thanks for a great talk. Just quick question. I believe that your time window will be for 24 hours of mild hypercapnia. I guess the question is why you are targeting 24 and not 48 hours. And the second question will be, once you get to those 24 hours, will it be back to normocapnia or will it be a gradual wean?
Thank you for your question. So the question was, we have an intervention period of 24 hours of targeted CO2 management. For the patients who are allocated to the higher CO2 group, what do you do after 24 hours if they still remain ventilated? So that we are leaving that to the discretion of the clinician. The evidence that we had to date, based on our pilot work and the retrospective work and the pilot work, was really contained to that first 24-hour period because it used the adult patient database, and then from that database we developed the CCC trial. So we don't have evidence to go further than 24. You may have good reason that it may be better to stay up there for longer, but we don't have any evidence to support that decision at the moment. Yeah. So would it be clinician decision?
Thanks very much, Glenn. Follow-up to the last question.
Yes.
Is would you try to avoid hypocapnia that's driven by the patient, which might be a bad thing, just like we avoid hyperthermia in our cardiac arrest patients, which might be a good thing.
Yeah. Even though I took longer than my allocated time, I didn't go into the background to show that that evidence is so strong that avoiding hypercapnia should be done in all cases, that someone who comes in hypocapnic or stays hypocapnic, they have worse outcomes. So the two intervention arms actually avoid hypercapnia, because we're asking you to stay in the normocapnic range or slightly higher than normal. We're not suggesting that patients have their hypercapnia tolerated at all. We actually try to make sure that you stay away from hypercapnia. So, in clinical practice, I think people would be trying to avoid hypercapnia, and we would continue to suggest that that's the thing to do.
It's just that they're waking up, often with a brain injury, they're hyperventilate. What do you do? Do you paralyse the patient, sedate them, or do you just let them breathe? That might be something which will come out in the study, because that's the clinical practice.
Okay.
After 2 or 3 days, who knows?
Okay. So once they're outside the intervention arm and you're no longer in a mandatory mode, it's really difficult to control the CO2, and you would have to use all of your skill to assess and wait comfortably the patients, and we wouldn't control it. But hopefully we'll see it in the data that we collect, because we're collecting gases all the way out to 40 hours and 72 hours if it's there. Definitely worthwhile. Thank you.
When do you anticipate to be standing there presenting some results?
So surprisingly or not, I think 3 to 3.5 years. The trials sites through Europe, given their population, we have high hopes for greater recruitment per site in those sites on an annual basis. And despite being 1,700, I still think in 3 to 3.5 years we'll finish recruitment. And then, so I think in 3.5 years we'll be able to come back and inform you of the findings. Yeah.
Yeah, great. Thanks, Sam.
Thank you.